Hey everybody, welcome back. Reed here. Today I want to briefly touch on PAC morphology, and I think this is a great EKG to demonstrate that. But first I just want to briefly talk a little bit about what we should expect normal to be so that whenever we see abnormal, then we can easily identify it and understand why. So, obviously this sinus P wave begins here at the sinus node that sits high within the right atrium. And when the sinus node fires off, which initiates the cardiac cycle, we get a wave of depolarization that spreads away from the right atrium, really away from the SA node sitting high within the right atrium, and the only way it can spread is down and to the left, right? So we get a vector of depolarization of a P wave of atrial depolarization that heads down and to the left, and the downward and leftward leads are leads 1 and leads AVF. And so you'll always hear me say when I'm interpreting EKGs to look for P waves that are upright in leads 1 and upright in leads AVF, right? Because that tells me that it's heading towards those leads, right? So anytime we look for a sinus rhythm, we should look for a sinus P wave. Now, premature atrial contractions are contractions that occur from an ectopic focus, meaning a focus that is not the sinus node, right? So here is a sinus node. An ectopic focus would be somewhere, say, here, for example. It could be anywhere, but say in this example, it's right here. And say it's sitting over here in the left atrium. If this is where a PAC fires off, well, it's going to send signal spreading away from that area. It's going to be heading in this direction, right? And notice that it's heading in a very different vector, with a different vector than a sinus P wave. Specifically, in this case, it's spreading away from the left, going from left to right. And that should produce a P wave that is what? It's going away from lead 1, so that would be negative P wave in lead 1, right? So if you see a negative P wave in lead 1, you're thinking, why is it going away from the left, right? Well, it must be some type of ectopic focus from the left side. And maybe another example would be, say you have a PAC that originates from low within the atria here. And if this fires off, it's going to send signal from the inferior aspect towards the superior aspect of the atrium, heading from low to high. And that's going to be away from these bottom leads, away from these inferior leads, leads 2, leads 3, and AVF, and maybe even produce negative P waves in the inferior leads. And that would tell me that my P wave is coming from somewhere low within the atria. Now, obviously, all of these PACs produce P waves, but every single P wave, right, atrial depolarization, will ultimately run into the AV node. And if the AV node is working well, the AV node will conduct that signal down through to the ventricles and produce a subsequent QRS. And that's why every time we see a PAC, right, say in this example, we see a PAC, we typically will see that QRS to follow, right? Which is why PACs will typically conduct to the subsequent QRS. So that is a brief overview of the PAC morphology and how, based on what it is in the specific limb leads, you can determine where that might be coming from. Let's take a quick example. It's just one EKG I want to go through with you guys, but you can apply this concept to any premature atrial beat. And what you'll notice when I look at this EKG, if I look down and say here in lead 2, we have a really regular rhythm here. You can tell there are some P waves that are generating QRSs, right? P to QRS, P to QRS, P to QRS. And then if you notice, we have this early beat, right? So we have some type of early beat. We notice that the QRS complex looks the same. And if we look in front of that early beat, we see there's some sharp atrial activity, right? This is a nice atrial activity. So that's a premature atrial activity or premature atrial contraction, and that premature atrial contraction representing early atrial activation. And then we see good subsequent AV conduction through to the QRS. And I know this is an ectopic P wave because look at the normal P wave. Just in this lead in itself, just in this lead, look at the normal P wave. So we have a normal P wave here, which is nice and upright. Normal P wave here, which is nice and upright. And look at this P wave. It's negative. It's a negative P wave. That tells me that the P wave is coming somewhere different within the atria. Now here's the hard thing, is not all P waves are going to land in the part of the EKG that you can perfectly look at the morphology. So for example, this early beat, this is the set of beats that we get to use for its analyzation, right? So we can only analyze this here. We get a glimpse of this PAC right here in lead 2. We see in lead 2, which is one of the inferior leads, it's a negative P wave. We see here in AVF, you get a small glimpse of that P wave negative. So we know that the P wave that's ectopic is negative in AVF. It's negative in lead 2. Well, those are 2 of my 3 inferior leads. So we can pretty much infer that this specific PAC is arising from somewhere low within the atria and sending signal up and away from leads 2 and leads AVF, right? So that would be just a negative P wave. And we obviously see that we get the resumption of our normal rhythm, and then look, we have another PAC, looks like the same morphology. So it looks like this ectopic focus here that produced this PAC is actually the same ectopic focus as this one. This is pretty neat. So you can see the morphology between these 2 beats is the same, and we can use that to suggest that these might be coming from the same location within the atria. So long story short, and the reason why I made this video is for you to recognize that you can actually look at the morphology of a PAC and map it out to where in the atria it's coming from, right? And it can be very helpful. If you see a recurrence, like you see here, you might think maybe there's a focus within the atria that is acting up and might need to see an electrophysiologist. So hope this helps. If you have any questions, throw them in the comments. If not, have a good rest of your day. Take care.